Hello everyone, welcome to case series discussion, interesting case series. Today we are going to discuss pediatric hematology case series. This is the first of the case series that we are going to present. Okay, so in the coming weeks we'll be coming up with new case presentations with new interesting cases with challenging diagnosis. So today we are going to see a pediatric hematology case which presented to our hospital, and we'll be seeing what happened to the patient later on. So this is a story of a 14-year-old female. So this is a case of a 14-year-old female, an adolescent female who had come to us with complaints of fever since 7 days. Okay, it was just fever with 7 days, and then she had pain abdomen for 5 days. So based on this symptom, when we asked further, she told that fever was of very high grade, that is about 103 to 104 degree Fahrenheit, and it was associated with 4 to 5 spikes of fever per day. So whenever children come with this amount of this frequency of fever with high grade fever, so parents are very much concerned, and this was going on for 7 days. And she had gone to some local hospital where diagnosis was not done, and she was given some medication, and then she had come to our center for further management. So she also had pain abdomen since 5 days, and this pain abdomen was mainly periumbilical pain abdomen, so around the umbilicus. So we had a 14-year-old female who had just two complaints, that is fever and pain abdomen, and this was around an acute history, that is it had been there for last 7 days with no other features. There was no vomiting, no jaundice, no bleeding manifestation, that is no bleeding from any other sites. Okay, there was no joint pain, there was no rash, no cough, no low stools. So there was no other symptoms at all, just a fever and a pain abdomen, and that too also an acute history. So acute onset fever and pain abdomen. So initially we thought that this could be an acute febrile illness. Okay, and so we proceeded ahead with examination. So in examination we found that the patient was febrile with a temperature of 104.2 degree Fahrenheit. So the temperature was 104.2 degree Fahrenheit. She had tachycardia of 128 per minute. Rest vital examinations such as respiratory rate, pulse pressure, pulse volume, CRT, extremities, all were within normal limits. Okay, so pulse pressure, pulse volume, respiratory rate, CRT, extremities was warm. Okay, so all these were within one normal limit, just she had a fever and tachycardia. So we examined with per abdomen, that is abdomen examination revealed that she had mild tenderness in periumbilical region as it correlated with history, and on examination of abdomen we found that there was liver which was 4 centimeter palpable under right coastal margin, which means her liver had enlarged. So there was hepatomegaly. Along with that, her spleen was also increased in size. She had splenomegaly. So on per abdomination finding, we found she had hepatosplenomegaly, but rest of the findings were within normal limits. So we had a patient who had an acute history of fever and pain abdomen, and she was febrile with tachycardia, and the only positive finding that we got was a hepatosplenomegaly. So along with this diagnosis, we thought it could be an acute febrile illness. So since this is time for tropical infection, so we were thinking of tropical infection which would cause this kind of picture, and fever workup was sent, the fever profile was sent, and we obtained this investigation pattern. That is, her CBC revealed that hemoglobin was 7.8, which was decreased. WBC was 4200, which was normal, but this was slightly suspicious because usually in infections WBC will be increased. However, there are many other infections where WBC count can be normal or there can be decreased as well, that is called leukopenia. And then platelet was 80,000. We had done further further investigation, that is we had done the DLC, we had done the RBC parameters also, but they are beyond scope of discussion here. I'm only going to discuss the positive findings. She had mild transaminitis, OT was 146, and SGPT was 122. Okay, and then as in a setting of tropical infection, we had done malaria card test and malaria smear. Okay, so that was negative. So, and then blood culture was sterile. However, in our initial investigations which we had sent, we got one important thing, that is her Vidal was positive and typhoid.IgM was reactive. So straightforward, a patient who presents with an acute history of fever with pain abdomen, who has hepatosplenomegaly, and whose Vidal and typhoid.IgM was positive, we kept it as a diagnosis of enteric fever. So this was a straightforward diagnosis, it was enteric fever. So we started immediately on injections ceftriaxone, that is we started at 20 mg per kg per day, which is a standard dose for enteric fever. And then we were expecting the patient to improve, because usually patients with enteric fever, they'll have decreased in fever spikes as soon as antibiotics are started, and thereafter they will be they'll be started on oral antibiotics, and then they will be discharged. So this will be a happy ending. So did this happen that way with our patient? No, it didn't happen. So what was wrong with our patient? So it was not a happy recovery. Why not happy recovery? Because after we started antibiotics, we expected the fever spikes to reduce, but there was no decrease in fever spike, and patients started to have high grade fever spikes of 104 degree, 104.2 degree Fahrenheit, even after starting of ceftriaxone. So we, as a protocol, we added the other antibiotic, that is azithromycin, because it could be a resistant strain, okay, or it could be a decreased dose. So it is protocol to add one more antibiotic when fever doesn't respond. So even after that, fever spikes continued. She still has started having 103 degree Fahrenheit, 104 degree Fahrenheit. So this was the point we realized that it was not just enteric. Is it just enteric? No, if it was enteric, it would have responded to ceftriaxone, azithromycin. So this must be something else. So something else must be going on with this patient. So we ordered a second line of investigation. So second line of investigations were sent. We were working up for the patient for mixed infection, because enteric fever is known to cause mixed infections. Okay. So we are working out for mixed infection. We sent samples for leptospira, we sent for scrub typhus, we sent for dengue, which can show biphasic illness also. We sent for atypical viruses, which can produce this kind of picture. So we were working up. We also sent for occult abscesses, which can cause this kind of picture for infective endocarditis, and all these came negative. And one set of investigation which had actually diverted our attention. So this was serum ferritin, fibrinogen, and serum triglyceride values. Serum ferritin values were high, serum fibrinogen levels were low, so serum triglyceride levels were high. So this combination, along with fever and hepatosplenomegaly, made us to think something else, and we went ahead with the bone marrow, and bone marrow investigation revealed this cell. This is nothing but this is a macrophage, and this macrophage has engulfed RBCs and platelets inside it. And now the diagnosis was almost clear. We had the following features with us. We had first, that is fever, patient presented with fever. We had splenomegaly, okay. Then we had decreased HB and decreased platelet, that is bicytopenia. We also had hyperferritinemia, and we had hypertriglyceridemia, and we had hypofibrinogenemia, okay. And along with this, we had bone marrow picture, which shows engulfed RBCs and engulfed platelets, blood cells, which is known as hemophagocytosis. So phagocytosis of RBCs and WBCs and even platelets. So along with this picture, this was satisfying a criteria for a disease. These are the 6 criteria out of the 8 criteria. The other 2 criteria are soluble CD25 is increased, and the other criteria is absent or low NK cell activity. So this 6 out of 8 criteria were fulfilled. Actually 5 out of 8 is enough to prove the diagnosis of something called as HLH, or we tell it as hemophagocytic lymphohistiocytosis. So what is this hemophagocytic lymphohistiocytosis, and why did our patient have this feature? So was it the enteric fever that caused hemophagocytic lymphohistiocytosis? Was it because of HLH that this patient had enteric fever, or was it something which was an incidental finding in this patient? Okay, so usually most of us don't know about HLH because this until you practice clinically. Okay, that also we can say that there are less cases of HLH reported as such in day-to-day practice. Okay, so when I was studying for my MBBS and my UG studies, I had read this in Robbins' pathology textbook, and then I had not given much of a thought to this. But now when I practice clinically, now I realize the importance of diagnosing HLH. This is because HLH is a syndrome which needs to be diagnosed immediately, or else the undiagnosed cases have high mortality. Okay, so what is this HLH? According to definition, HLH is a syndrome which is characterized by a hyperinflammatory state. So it is a syndrome characterized by hyperinflammatory state which leads to unremitting fever. See, our patient also had unremitting fever. Then it can lead to cytopenias, bicytopenia, pancytopenia. It leads to organomegaly, hepatosplenomegaly, as was seen in our patient, which all this causes, along with this increased inflammatory markers. Okay, all this leads to hyperinflammation. So in a nutshell, this is something which is related to something called a cytokine storm. Okay, during COVID we had this term called cytokine storm. So HLH is also one of the causes for cytokine storm. So it causes hyperinflammation, which leads to multi-organ failure and eventually death. So the importance of HLH is you have to treat it and diagnose and treat it early, because it has high mortality if left untreated. So let's go into further to see what happens in HLH. Okay, so HLH is of two types. One is primary, that is familial HLH, and next one is secondary, which is known as infection associated HLH. There are a few other types also which are given here. This is a table from Nelson, but we won't go into depth. Okay, and this HLH comes under a category known as childhood histiocytosis, where one more common thing which you will see is Langerhans-Sells histiocytosis, if you remember. So primary and secondary HLH, what is the need to differentiate it, we'll see in the later part of the video, and what is this primary and secondary, we'll see it now. Okay, so what happens in an HLH? HLH was first described in viral infection. Okay, so this is the model we'll see to understand the pathogenesis. So any viral infection or any other bacterial infection or any other infection, okay, so these viruses, these will enter into this will go into the cells. Okay, this will go into the virus, will enter into the cells, and these cells will be presented by macrophages to this cytotoxic T cells. Okay, these cytotoxic T cells, CD8 plus, will be activated because of this virus infected cells, and this activation will in turn cause macrophage activation, and macrophages will kill the cells. This is the normal pathway. But what happens in HLH is there is a defect in the pathway which causes the release of which results in the activation of cytotoxic T cells. So the cytotoxic T cells are activated in an uncontrolled fashion, which leads to increased macrophage activation. And once macrophages are angry, okay, remember, when macrophages are angry, they'll eat whatever they get. So they will engulf RBCs, they will engulf WBCs, they'll engulf platelets. So this causes hemophagocytosis. And also these macrophages will release this IL-6 interleukin 6, which will cause tissue infiltration and destruction. So if you go into depth between what happens between this CD8 and this macrophage activation, you can see here there are two important enzymes or molecules which are known. One is perforin and one more is granzyme. Why I'm telling this is because in the condition known as primary HLH, which we saw, which is because of genetic mutation, there is mutation in this granzyme and perforin and few other molecules also, which will cause uncontrolled activation of CD8 plus and macrophages. Getting my point? Viral infected cells as such can cause increased activation, as well as these molecular mutations will also cause increased activation, which finally leads to hemophagocytosis. This is one more table from Nelson. See, this genetic mutations of perforin mainly, and this causes primary HLH. Okay, this causes primary HLH, and the rest, like malignancy, also can cause. Infection is usually a trigger. Okay, infection is usually a trigger. There are acquired immune dysregulation syndromes, and there are also autoimmune and inflammatory disorders. So mainly these causes something called as MAS, that is macrophage activation syndrome, which is similar to HLH. Okay, so all these are secondary causes of secondary HLH. Okay, this is the primary genetic, and this is secondary, which are other causes, mainly malignancy, then autoimmune disorders and infections. So these are the causes of this one. You will see here, you have to remember only two things. One is familial HLH2 and familial HLH3, because familial HLH2 causes perforin and UNC. These two account for 60% of the mutations. Okay, these are the two things you should need to remember. Rest of the syndromes you can remember if you like. Other causes of secondary HLH which we found in our patient, if you see this table, see there is salmonella here. So salmonella is a cause of secondary HLH. So viruses, EBV, CMV, have herpes virus, Brucella, Mycobacterium, Leptospira can also cause. Okay, and protozoa like leishmania can cause malignancies, leukemias, lymphomas can cause rheumatological disorders, cause MAS, that is macrophage activation syndrome. Okay, and this is a table given in Nelson. All these causes are given, but I think you don't have to remember all this because it's a very long list, and it is practically not applicable. So you just have to remember these things, which are the causes. Okay. So moving forward to what are the clinical features. So it is impossible to differentiate between primary and secondary HLH, but usually primary HLH will be like, it will have a gradual onset and then it will be more severe, but it will be gradual onset, and secondary HLH will be acute onset. Okay, acute onset, and it will be more severe initially. So this is line from Nelson, that is familial and secondary have remarkably similar presentations. Okay, and usually characterized by fever, rash, weight loss, irritability. So this is a presentation of a primary HLH. For secondary HLH, we have, it is very severe, and the case of secondary HLH may be camouflaged by a primary disease. So in our case, see how diseases and the textbook is correlated. See, this is what you should also do. You should go to wards, you should go to the patient, and then you have to correlate the patient along with whatever is given in the books. Okay, see, our patient had this secondary HLH masked by enteric fever. So this is exactly given in Nelson. Initial presentation is almost always very severe, and case of secondary HLH may be camouflaged by a primary disease process. Okay, and here physical examination which revealed hepatosplenomegaly, lymphadenopathy, respiratory distress. So all this can be seen. Okay, so secondary HLH typically presents at an older age. Our child was also 14 years. So this is how we correlate textbooks and patients. Okay, that's when you actually learn. So how do we diagnose HLH? So this is the criteria which we followed. So there are two criteria. One is if you have a molecular diagnosis, that is with any PRF mutation, that is perforin mutation or SAP mutation, then that is diagnostic of HLH. HLH is confirmed. If not, then you have to fulfill 5 out of the 8 properties. Okay, say fever, which was there in our patient, splenomegaly was there, bicytopenia was there. Bicytopenia means how much? HB is less than 9 and platelet is less than 1 lakh. So these both are present in our patient. Our patient's HB was 7.8 and platelet was 80,000. Then we had hypertriglyceridemia in our patient, 329. We had hypofibrinogemia also, 111. It should be less than 150. Ours was 111. Hemophagocytis was evident on bone marrow, and there was hyperferritinemia also. So it was in the range of 2000s. Okay, so we had fulfilled 6 out of 8 criteria. 5 out of 8 is enough. So we had a diagnosis of secondary HLH, which is secondary to enteric fever. Got my point? See how the diagnosis changed. If suppose we didn't know that HLH entity existed, so we would have treated the patient thinking that it is a case of resistant enteric fever, and we would have gone a step further, and like it would have altogether brought a different outcome. It should have been worse. Okay, so knowing things can actually change the way you manage patients. So next, how do we treat HLH? So primary HLH, see, what is HLH? HLH is an hyperinflammation condition. So whenever there is hyperinflammation condition, you have to bring down the inflammation. So you have to give drugs which will bring down inflammation. So one of them is steroids. Okay, so treatment includes steroids, corticosteroids. Second is chemotherapy can also cause decrease in inflammatory state. So we'll give in primary HLH mainly, we'll give etoposide, cyclosporin, intrathecal methotrexate. Okay, because primarily HLH is dangerous. Okay, and that inflammation should be brought down. So we go aggressively. But what about secondary HLH? In secondary HLH, this is the line from Nelson. Okay, the diagnosis. Acute onset of secondary in the presence of, in this case, treatment of underlying infection is coupled with supportive care. Okay, underlying disease should be identified and successfully treated. So in our case, the patient had underlying enteric fever, and that underlying enteric fever, if it is treated, then slowly the HLH symptoms will come down. Okay, getting my point? So what we did was we continued our therapy with antibiotics for enteric fever, and we saw if patient is going to improve with that. If the patient was not improving or worsening, then we had to add steroids, and this steroid will be for long duration, like for 8 weeks, and there is a protocol for that, and we'll be discussing it in our future videos. So our patient was diagnosed with secondary HLH based on criteria. Patient responded gradually to antibiotic. Gradually, patient had decrease in severity of the fever spikes, and there was decreased frequency also. And finally, patient became afebrile, and all the lab parameters came to normal. And finally, patient was discharged. So this was a happy story for us. So what we thought initially to be a simple enteric fever turned out to be a challenging secondary HLH, which was secondary to enteric fever. So what are the take-home lessons from this video? First, always think of HLH whenever there is a prolonged fever. There is a prolonged fever, you are giving some antibiotics, and then whatever you think the outcome is not present, so you will upgrade antibiotics, and then still the fever is not coming down. Now you are working up for a pyrexia of unknown origin. Okay, and one of the causes in that which you have to keep in your mind is HLH. Second, HLH is always underdiagnosed. Okay, keep this in mind. If you have this suspicion of HLH, then your outcome is going to be different. Okay, because diagnosis and treatment is priority, because it can be fatal. So this was an interesting case which was in a ward which actually was a very challenging one, because whenever you have a fever that doesn't respond, okay, whenever you have a child with fever that doesn't respond to anything you give, then it actually scares every pediatrician. So we'll be coming up with many more episodes in the future. Okay, and next week we'll be having a new episode. Till then, stay tuned.